to this TNOA PG teaching program. This is the 14th program. Today we have a senior faculty, Professor of Orthopedics, Dr. Manohar. He is from SALEM Medical College. He is one of the senior Professor of Orthopedics in Tamil Nadu. He is the current Vice President of Midwest Ortho Society. Got Best Doctor Award from Tamil Nadu, Government of Tamil Nadu. And he's also got, to his credit, he has got 6 publications to his credit. And he's going to deal today very important topics, the short case discussion. This is important because most of the time the long cases, we know the diagnosis. We know the diagnosis in the sense we have limited scopes, unstable hip, coxavera, something like that. But elbow, there is a wide range of cases. You can give any number of diagnoses is possible. The postgraduate feel it is difficult to crack the short cases. Even if you have a marginal drop in the long cases, we can compensate by doing it in the short cases. So that is why the short cases are given importance. Today, Dr. Manohar will highlight you about roughly about 3 cases. And welcome my postgraduates, Dr. Akhilesh, Tirunelveli Medical College, and Dr. Parithuran from Madurai Medical College. And both of them will interact with our professor, and it will be a good learning experience. Over to Professor Manohar.
Thank you, sir. First of all, I thank TNOA. Sir, am I audible, sir?
Yes, you are audible. You are audible.
First of all, I thank TNOA President and General Secretary and advisors for the PG teaching program. And also, I wish best wishes for the postgraduates. Thank you, sir. Presentation start பண்ணிடலாம் sir.
Yes, sir. Yes, sir. You can give the share screen, sir.
Who is going to volunteer for the first case? Arjun or Parithuran? Arjun or Parithuran, who is going to? Hello?
Myself.
Myself, me Pari. Okay?
Sir, Pari. Pari, sir.
Pari, you listen to the first case. Sir will tell you some clinical details and he will start asking questions. Okay? The
Yes,
first case is to Pari. Yes.
Yeah. Thank you, sir. This 37-year-old female homemaker had pain of left ankle for past 6 months, and for 4 months she had swelling and discharging sinus for 2 months, and she had difficulty in walking for 1 month. On examination, warmth tenderness was present, and there was a boggy swelling over the ankle, and there was a heel length decrease by 1 centimeter, and scar present over the posterior aspect and medial aspect.
Yes, sir.
And there was a fixed equinox deformity of 45 degree, and inversion eversion of 20 degree was possible. This was the clinical picture.
Yes, sir.
Do you need any other information in history or examination?
Sir.
Hello?
Sorry, sir.
Do you need any other information regarding history, in history or in examination?
Any history of trauma, sir?
No, no history of trauma.
Fall from height?
No. And any other history?
Any other medication, sir?
No medication. Any other?
Limp, sir? History of limp, sir?
Yeah, history of limp was present. And any other regarding pain?
Pain on heel strike or during all phases of gait cycle, sir?
Yeah, she had pain in walking.
Specifically during which phase of gait cycle, sir? Like on heel strike or?
Patient cannot differentiate. Patient say pain.
She has pain in walking.
That's
okay. That on examination.
And any other history?
Fever, sir? Fever?
No history of fever.
Groin tenderness, any lymphadenopathy there, sort of?
Yeah, we are still in history.
No tenderness in the groin or popliteal region, sir.
Oh, we are in history. Do you want to know whether she had any night pain or wrist pain? Or pain, whether she had any diurnal variation? No history
Yes,
of night pain, no history of wrist pain, and
night
no
craze.
no night craze, no diurnal variation.
I would like to go with the X-ray ankle and X-ray foot AB, X-ray ankle AP lateral and X-ray foot AP oblique, sir.
Okay, they're shown in the X-ray we want. This is the X-ray. And you were asking about the inguinal lymph nodes.
Yes, sir.
So, which lymph node will you palpate, or which is more significant in this patient?
Horizontal and vertical group of lymph nodes and superficial in the superficial group, and in the
no, specifically for the knee and foot disease, which is more prominent, or it should be examined. It should be deep inguinal nodes. Okay. Any other? History-wise, any other thing you want to say? So there was a sinus. Do you want to examine the sinus?
yes, sir. Any discharge from the sinus, single sinus or multiple sinuses, sir?
She had pus discharge followed by serous discharge, and there is no history of bony spicules. No history of bony spicules.
No bony spicules, not not pointing towards osteomyelitis, sir.
Okay, no history of bony spicules. Any other thing about the swelling?
Sir?
About the swelling?
So in the plantar aspect or in the retrocalcaneal region, sir, involving subtalar joints, sir?
The posterior aspect, she is having the swelling.
More of an involvement of ankle joints, sir.
Yes.
The X-ray also looks, the ankle joint looks hazy, more hazy, with posterior shadows just above the calcaneal region, sir. Range of movement, okay. Contact history, sir. Any?
No history of contact history, and no history of conscious symptoms.
Loss of weight, loss of appetite, sir.
No history of conscious symptoms.
Previous history of ATT, sir.
No. Okay, on general examination, the patient was moderately built and nourished, no pallor, no icterus, and no significant lymphadenopathy. Local examination, hip and knee in neutral, left ankle is plantar flexed, and more of neutral in rotation.
We are suspecting any synovial effusion here, sir.
Okay.
Is this sort of a synovial reaction causing any synovial effusion, sir, in the ankle joint, causing pain during walking, accounting for the limb? We can go for any synovial biopsy.
No, actually, in history we are told that the heel length was decreased for 1 centimeter.
Yes, sir.
And what's your probable diagnosis on clinical examination?
The differential diagnosis.
Okay, sorry. Yeah, differential diagnosis.
Any tuberculous involvement, sir, of the ankle? No bony spicules or osteomyelitis, sir. Osteomyelitis followed by tuberculous involvement of
Then one by one. The first priority, then go to the second, like that is on.
sir.
What is the first differential diagnosis? What is your second differential diagnosis? Like that, you must go on.
Yes. First, I would like to go with tuberculosis of the ankle joint, sir.
Okay. Second,
Osteomyelitis of distal tibia or talus, but there is no history of trauma, which is against.
do osteomyelitis always need a trauma?
No, sir. No, not necessarily.
And then why do you want a history of trauma?
Okay.
And you are seeing the X-ray. Then why do you want to come on distal tibia or talus or something like that? You are seeing the X-ray. You can boldly say where is the problem. Okay. What is the third differential diagnosis? Pain, swelling, discharge, apart from infection.
Any tumor, sir?
Like
GCT of talus?
have you seen the X-ray, man?
No, sir.
Is there any osteomyelitis? Then why do you
No,
want
sir.
to get GCT?
You just see the X-ray. What do you see in the X-ray? How will you read the X-ray? Read the X-ray.
Ankle joint is hazy, sir, with
No, you have to.
the plain X-ray of the left ankle AP and lateral showing
Of an adult
of a mature skeleton.
skeleton. Mature left leg with ankle.
Left leg with ankle AP lateral of a mature skeleton.
Yes.
Showing hazy changes over the ankle joint.
Okay.
With posterior extension, sir, in the retrocalcaneal region. Calcaneum appears normal. No lytic lesions or previous no history suggestive of any calcaneal height reduction, sir. No evidence, sir. Subtalar joint looks fine.
How is the tibiotalar joint?
Right.
Tibiotalar.
Tibiotalar joint looks a bit hazy, sir.
Hazy and joint space.
Joint space up.
You are not able to find it.
Okay.
Sure. Okay. Okay. No problem.
If you're reading an X-ray, you have to start from the soft tissue, then go for the bone, general condition of the bone, then joint and everything. Okay, one by one you have to go.
Yes.
So coordinated நம்ம சொல்லலாம். சரியா? So what is the appearance, general appearance of the bone? இதெல்லாம் தான் சின்ன சின்ன points. It will be favoring your diagnosis.
சரி.
She's a 26-year-old lady. Okay. So how is the bone here? Any difference?
Faces are fused, mature skeleton, sir.
Okay.
No evidence of no, not looking any osteoporotic, sir.
Okay. Then how is the tarsal bones?
Or you have to unmute.
One second. Tarsal bones on the AP and lateral views, I'm not really able to comment anything, sir. I would like to have a foot AP oblique, sir.
Okay, this is the X-ray available. This is the available X-ray.
Talus looks bit sclerotic, sir.
So another you are saying about some osteomyelitis. Whether you can see. No, you are saying one of the DD for osteomyelitis.
Yes, sir.
Whether you can see any other related things in X-ray.
No lytic changes, sir.
Okay.
Joints.
Okay. Here the joint space is reduced. There is a uniform reduction of the joint space, and there is a osteopenia over the generalized osteopenia is there, and also over the tarsal. And you see the is in the weakness.
No, sir. உங்க mic close ஆ வச்சுக்கோங்க. கொஞ்சம்
Okay.
yes.
The foot is in equinus. Okay. So after you have seen the X-ray, any other investigations would you like to do? Any other investigations?
Yes, view, sir. Weight bearing, same view with weight bearing, sir.
Okay. So there is a in history we saw that there is a boggy swelling.
Yes, sir.
And you said the swelling is due to synovial. There may be a synovial fluid and there may be a synovial thickening. Okay. Hello.
Pari?
Sir?
Dr. Pari?
Sorry, sir.
Yes. Yes, sir.
Oh. So what other investigation can you do? You have taken a plain X-ray.
CT of the joint or soft tissue involvement to rule out anything. MRI, sir. I would like to go with an
Okay.
MRI of the ankle, sir.
Okay. 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 Any other? MRI is available. I'll show it. Any other thing?
Distal region, sir. The foot, left foot, sir. Distally, X-ray.
Pari, ஒன்றும் இல்லை இப்போ நீங்கள் உங்களுக்கு this the MRI.
So now read the MRI, Dr. Pari.
Yes, sir. Fluid collection, there is evident fluid collection in the ankle joint, sir.
Exactly.
With soft tissue tracking and the involvement of the distal tibia, sir. There is some involvement of the distal tibia.
And some erosions, can you find it in the talus? Few
Yes,
erosions
the
in the articular surface.
Yes, sir.
Am I right? Yes.
Yes, sir.
Yes.
Sir, actually, when you start to read MRI, you have to say it's a T2 weighted or T1 weighted image. Like that, you have to start. Okay. Pari, is it audible?
Yes.
Okay. Okay.
Yes, sir.
Okay. Okay, you have an MRI. Any other thing? Any other investigation like you wish to do?
Biopsy or aspirate, sir.
Very good.
For
Okay.
AFB and culture sensitivity.
Okay. Then biopsy, aspiration, synovial aspiration for AFB, culture
sensitivity and AFB.
Then any other thing?
To detect the soft tissue tracking, any radio opaque dye injection study, sir.
What
is
call
it called as? Radio opaque dye injection. Arthrogram? You want to see the joint, not the sinus.
Sinogram.
Okay. Then
So you taken a synovial joint aspirate, and we can. What is the probable diagnosis for this patient now?
Tuberculosis, sir. I would like to confine myself to tuberculosis of the ankle joint.
Okay. What are the positive points for tuberculosis?
Pain and swelling, sir, in the history.
Okay.
Lymphadenopathy, you said, sir.
Okay.
X-ray, there is finding in the ankle joint, sir. Talar looks sort of talar dome involvement, and under the ankle joint there is some lesion, sir.
Okay.
In the MRI, there is a fusion with soft tissue tracking, sir.
Okay.
And you said there is a discharging sinus, sir, in the history.
Yes. So
Without any
first thing tuberculosis is more common in our country, and there is a wasting of calf muscles and history of sinus discharge. And against tuberculosis, what are the points here, history wise?
Against tuberculosis, sir.
Yeah, she doesn't have any constitutional symptoms.
Sometimes, sir. Loss of weight, loss of appetite, sir.
Yeah. What are the other differential diagnosis? TB is one. The other thing is monoarticular joint. Rheumatoid. So, what are the positive points for here?
Early morning pain.
Night cry shouldn't. There was no night cries or night pains.
Yes. Very good.
It's against.
Okay. She does a monoarticular type, and she is a female, and there is a ankle swelling.
Yes, sir.
Huh? Okay.
Yes, sir.
And if a synovial joint aspirate, we will take the synovial joint aspirate and we send for culture sensitivity and look for AFB, and also we can do tuberculosis ku நம்ம rule out பண்றதுக்கு என்ன பண்ணலாம்? Joint aspirate.
To detect any multi-drug resistance is there.
Okay. You can do a PCR. Okay. How will you manage this patient?
I will empirically start this patient on ATT, sir. Category 1.
Okay. Okay. Category 1. How many categories are available now?
Sir?
How many categories are available now?
Category 1 and category 2, sir.
Okay. How long will you give? What drugs?
SRZT, sir.
Now, how long will you give drugs?
I would like to follow it up with an X-ray, sir. Whether the joints become quiescent or not, I would like to clinically follow up with ESR,
Okay.
sedimentation rate, sir.
Okay.
How long? 10 months, sir.
No, you said you will follow up with an ESR and X-ray. When will you take the next X-ray?
Yes, and clinically, sir. Clinically, whether the symptoms are improving or not.
Okay. When will you take the next X-ray? Follow-up X-ray?
After a month. for a month.
Yes, sir.
Okay, what will you see in the X-ray? Whether you have started empirically, you have started a anti-tuberculous drugs. So
Yes, sir.
what will be the picture if you say that she is good with the ATT and she start improving? What will be the picture of the X-ray?
Of the ankle, sir?
Yeah.
The haziness in the ankle will start to decrease, sir, and there will be sclerosis, sir. Sclerosis in the joint.
No.
The tarsal bones are not involved, sir, in this X-ray. More of a distal talotibial joint only involved, sir, here. I look for any arthrodesis changes, sir. Sclerosis, joint face reduction.
No. My question is, you said you take an X-ray after a month. She is on ATT, and you take an X-ray, and how will you confirm whether she is whether we can continue the ATT or we have to discontinue the ATT? Otherwise,
liver.
No. By X-ray, whether we can see anything. You said there is.
What he means to say is, when you will say the disease is cured of the patient, at what point of time you will say the disease? I mean, complete ATT. It is not discontinuing. Completing ATT. When will you complete the ATT?
The recommendation now for extrapulmonary TB is 10 months course, sir, for skeletal TB.
Okay.
4 plus 6, sir. But
that's right answer. It's a really right answer. 10 months, sometimes even more we have to give, depending upon the patient. Minimum time of 10 months is needed. Okay.
You have to see the remineralization of the bone and reformation of the bone trabeculae. Okay. What will you do? You are started ATT. What will you advise? What other advices will you give, or what will you do for the patient or the joint?
I would like to supplement it with BK slab, sir. Immobilization helps.
Okay. For how long?
Until pain
For 6
subsides.
weeks, sir.
Sorry?
For a month.
For a month. So now you have to give up to 12 weeks. You have to be given. Okay. You said something about the arthrodesis.
Yes, sir.
Okay. When will you plan for arthrodesis?
This looks a sort of quiescent picture, sir. When the tarsal bones or subtalar joints are involved, and this fulminant involvement, you'll go for arthrodesis, sir. When there is instability of the ankle.
Yes, very good.
Instability of the ankle. Okay.
And
Persistent pain.
Sir?
Persistent pain is another answer.
Pain is an indication.
Pain and instability.
Okay. How will you plan arthrodesis? What is the position of the ankle should be for an arthrodesis?
A functional position, sir.
Okay.
With from neutral, a bit of equinus is preferred, sir. 5 degrees or 10 degrees of equinus.
5 degrees of equinus.
Then?
Neutral.
No, one person should answer. I have two voices. Dr. Pari alone can answer. Others can put it in the chat box.
5 to 10 degrees of equinus, sir.
Yes, exactly.
Functional position of the ankle, talo.
Then? How much of valgus, how much of rotation, inversion, eversion, all those things.
Hind foot and a bit of valgus, sir.
Valgus. Then that's all.
Then all other range of movements in neutral.
It's a neutral flexion and or extension, and for 5 degree of external rotation and valgus of 5 degree. Okay. Okay.
So what you have to add is 5 degree of external rotation. Okay, Dr. Pari. Okay.
Yes, sir.
Okay. How will you do an arthrodesis? What are the methods of ankle arthrodesis?
Pan-talar arthrodesis, sir. This is.
Okay.
In incision starting from the distal leg, extending onto the dorsal crease and onto the dorsum of foot, sir. And we open the extensor retinaculate, transverse and the Y bands of the extensor retinaculate. We retract the
open the extensor retinaculum transverse. What do you mean by opening the extensor retinaculum by transverse?
There are two bands of the extensor retinaculate, one transverse band proximally and the Y band distally, sir.
Okay.
Distally, then we retract the structures behind the extensor retinaculate, sir. Tibial is posterior and the extensor hallucis is longest medially. Then the artery and nerves to be preserved, anterior tibial artery and the anterior tibial nerve to be preserved. And laterally we have peroneus brevis and the extensor digitorum, sir. We retract those things laterally and we expose the capsule of the ankle joint. Through a transverse incision, we remove all the synovial debris or
granulation tissue, infected granulation tissue. Right? Then
we exposing the talotibial joint by plantar flexion. We expose the articular cartilage of the talus, and we debride the articular cartilage, and we pack that with cancellous bone grafts from the iliac crest, harvested from the iliac crest. And we put two Charnley's situator we can put, sir. Two Steeman pins, sir. One in the body of talus and one in the distal tibia with a compression device. We are supposed to compress it. After a period of 4 weeks or 6 weeks, we remove the Charnley's and put the patient on a BK cast.
Okay. Then you have to
can
give
I ask a question, sir? No,
sir?
sir.
Yes, sir. Yes, sir.
You want to put only shank screw for the Chandis clamp? What type of pins you will put in the distal tibia and the talus to get a compression of the articular surface? You said it you do Charnley's arthrodesis. Dr. Pari?
Yes, sir.
Yes.
Yes, sir.
So will you put a regular shank screw Steinman pin like that, or is there anything special?
Enhanced pin is there, sir. There is only screws in the middle portion of the pin, sir. A better purchase can be achieved.
Yeah. Okay, fine.
Yes.
Now, sir, you can carry on.
Yes. Oh no. How will you rehabilitate the patient? You have done arthrodesis, and
Yes, sir.
actually
In
you have
the
to get
functional position, sir.
yes. So, what are the things will you say in taking a consent? You have to take a pre-consent before the arthrodesis. So, what are the things will you say? So you were kept
There can be, sir,
you were keeping the ankle in
functional position, sir. The
functional position.
ankle range of movements will be lost. That will be
Yes.
clearly explained, sir.
Oh, okay.
Settling of the infection should not be assured. There can be persistence of infection. Obviously, we are supplementing it with ATT, and we are expecting subsidence of the infection, sir.
Okay. How will be the length of the limb?
Shortening, sir.
Yeah. So you have to explain the shortening. And we have to
Sir?
Till heel sole rise, then you have to explain the limb length also.
Yes, sir.
Okay, good. Sir, can you move on?
Sir, Manohar, sir, before moving on, there are
Very
some
good.
questions in the chat. So I will answer the chat box, then go to the next
Okay.
case, sir. Okay. The first question is
Okay,
Dr.
sir.
Aravind Chavak thought about differential technique tarsal coalition. A tarsal coalition being a
Oh.
congenital condition and it is bilateral, present with the pain or most of the time painless, flat foot, and it won't present as a sinus, discharging sinus, and asymptomatic for the past 32 years. So tarsal coalition cannot be possibility because it is a congenital condition. It has been presented. If it is painful, it has to be pain from the beginning. There will be no discharge discharge in a case of tarsal coalition. That has to be ruled out. The other Dr. Kumar had told about diabetes. That is a very good differential diagnosis. Please include leprosy also, because you have to think in terms, because there is a discharging sinus, you have to think of a neuropathic joint also. Dr. Pari, you might have asked about whether the patient has got a sensory loss in the limbs. Dr. Pari,
Yes,
you
sir.
have to think about, you need not concentrate alone, TB alone. Think about neuropathic joint. Can be also present as discharging sinus. So you have to rule out leprosy. And sir told about rheumatoid arthritis. When there is a rheumatoid arthritis, Dr. Pari, you have to look for in the general examination, is there any features of rheumatoid? Dr. Pari, you must have asked, sir, whether there is any features of rheumatoid. Can you tell me some features?
Early morning stiffness.
No, examination, general examination wise. General examination in case.
On and off swelling.
No, general examination, what in case of tuberculosis, I'm very sorry, rheumatoid arthritis. In case of rheumatoid arthritis, in general examination, what are the things you look for?
Deformities of the toes.
Okay.
Fingers.
Okay.
Polyarticular involvement.
Okay. Anything in the forearm? Extensor nodules. You can look for extensor nodules. Okay. Although if you have to think about all those conditions. Don't narrow your diagnosis to one particular thing. You think about all differential technique. You have to think about wide possibility. Then you rule out subsequently. Okay. So these are the things which you have to. You can even think about gouty arthritis, but it is very and rare. If it is gouty arthritis, which joint it goes for? Which joint is involved? Metatarsophalangeal. So gout. Okay. So these are the things you have to think about. Okay. Right. Shall we move on to the next case? Dr. Manohar,
sir, 1 minute, sir. Just to add, sir, actually in our OPD, we see more number of cases of post-viral arthralgia who present with swelling of ankle, which is in the synovitis stage. For that, we should be aware of that, and we should be ready to give a plan for the treatment for even the post-viral arthralgia, which are the more cases present with ankle swelling.
Okay, sir.
Okay. Can you move to second?
Yes, second case.
Second case. Yeah.
Akhilesh, Dr. Akhilesh, where is Akhilesh? Since Akhilesh is not available, I think Dr. Pari has to again answer the same question. Pari? Are you ready to answer? Because Akhilesh is not available. Unmute panningla Akhilesh. Ramesh? Akhilesh irukara?
Sir, Akhilesh sir is there only.
You unmute him.
Yeah, I've done.
Akhilesh.
Akhilesh sir,
Akhilesh line la vandingla?
Sir.
Okay. Sir. Right. You are right. Okay. Akhilesh is here. So he will take the questions. Yes, sir.
So good evening, sir.
Good evening. Good evening, Akhilesh. Akhilesh, this 26-year-old male patient,
okay, sir,
who is a painter by occupation, attended an OP with the history of pain and swelling in his left foot for past 1 month. and there is no history of trauma, no history of fever, no history of weight loss or loss of appetite, and no significant past medical or surgical illness, and no significant family history. This was the X-ray of left foot. Can you give any differential diagnosis or?
Sir, can you please share the history slide, sir? Thank you, sir. So, as per history, it's a young age patient. The patient is only having pain and swelling, that too for acute period for 1 month.
Yeah.
So, since the patient is having pain and swelling, it can be a form of inflammatory condition or a infectious condition, sir, or it can be a tumorogenic condition, sir. Sir, am I audible, sir?
Yeah. Continue, Akhilesh.
Sir. So should I directly comment on the X-ray, sir, or can I?
Yeah. You read the X-ray.
So it's an X-ray of left foot, AP and oblique views of a mature skeleton, including the ankle joint, sir.
Okay.
The patient X-ray shows a small lytic lesion in the first proximal phalanx, sir.
Okay.
Distalmost part of the proximal phalanx, sir.
Okay.
Then, so the oblique view, again in the first metatarsal head, there is a contained lesion, sir.
Okay.
The oblique view, sir.
Okay.
So there is no periosteal reaction or any soft tissue swelling surrounding it, sir.
Okay.
And the intermetatarsal joints, the IP joints and TMT joints seems to be intact, sir. There is no obvious fracture, so there is no obvious subluxation, sir.
Can somebody still more zoom it?
Yeah.
Zoom
Sir?
பண்ண முடியுமா? இன்னும் கொஞ்சம் zoom பண்ண முடியுமா?
The part.
Okay.
Okay, sir.
Okay, sir.
Akhilesh, can you see? Please.
Yeah, it's visible, sir. Thank you, sir.
Yeah.
So there is a definitely lesion which is present at the proximal aspect of the first metatarsal, sir.
Okay.
So then there is a similar lesion which is a lytic lesion which is present in the distal aspect of the first PPX also, sir.
Somebody is asking what is comment about the second metatarsal shaft, Dr.
So second metatarsal shaft also there, it seems to be an old malunited fracture, sir.
Okay, fine. Right.
Then the tarsal portion, the metatarsal joints as well as the IP joint seems to be intact, sir. There is no obvious fresh fractures or any obvious subluxation, sir. And the joints also, there is no obvious arthritic changes also. It's not present, sir.
Okay.
Then the calcaneum and the talus also, as per the X-ray, it seems to be normal, sir. Sir, so I would like to give a differential on this lesion, sir.
Okay.
Sir, first differential, it looks like a cork sequestrum, sir. It can be a tuberculosis.
No, you have said there is a lesion in the
So proximal aspect, distal aspect of first metatarsal, sir. In the oblique view, sir.
Distal aspect of the first metatarsal.
First metatarsal.
Okay. Any other thing?
Then in the first proximal phalanx also, distal aspect, there is a lytic lesion, sir.
Metatarsal is it like a sesamoid or a lesion?
Sir?
The metatarsal head, you are commenting about the metatarsal head. It looks like a sesamoid or a cork sequestrum.
So sesamoid, sir, The sesmod is present bit of a lateral position. It's in the oblique view. It's seen, sir. And
Another, can you see the proximal phalanx of third toe?
so sir, base of the
zoom பண்ண முடியுமா?
proximal phalanx. As a base of the proximal phalanx of the third toe is also showing a small lytic lesion, sir, on AP view, sir.
Okay.
Okay, clear. So you're seeing a lesion over.
The base of the third proximal phalanx, sir.
Okay.
And also in the distal aspect of the first proximal phalanx, sir.
Okay. Proceed.
Sir, I'd like to give a differential diagnosis, sir.
How will you explain the lesion in the X-ray?
Sir, so it's a well-defined lesion, sir.
Okay.
Well-defined lesion, and there is a total lysis in the center of the lesion, and there is a sclerotic margin which is present around the lesion, sir. So in the oblique view, the lesion is extending into the IP joint also, sir. There's a small extension into the IP joint also, sir.
Which one? Here you see the border. Okay.
Sir, there is no obvious periosteal reaction or any surrounding soft tissue inflammation, sir.
Okay. So it's a well-defined lesion, osteotic lesion.
Sir.
Whether it is eccentric or?
Yes, sir. It's eccentric, sir. It's more towards lateral side, sir.
Okay. Whether any cortical breach?
Yes, sir. In the oblique view, there is a cortical breach. There is an extension into the IP joint, sir.
Okay. Any whether you can see any soft tissue involvement?
As per this X-ray, there is no obvious soft tissue reactions or reactory inflammation. That's it's not visible, sir.
Okay.
And IP joint also seems to be intact, but there is no arthritic changes, sir.
Okay. How will you proceed?
Sir, I can give a differential diagnosis as per the history and the X-ray, sir.
Okay.
Sir, first it can be benign tumor of the proximal phalanx, sir. It can either be an enchondroma or an osteoidostoma, sir. So next differential can give to an infectious condition, sir, like a Brodie sepsis. Third differential, sir, we can give to sir tuberculous sequestrum, coke sequestrum, sir.
Okay. What are the points favoring your diagnosis and against your diagnosis?
Sir, patient for a infectious differential, sir, the patient is having an acute presentation. Past 1 month only, patient is having pain and swelling, sir. But against means the patient is not having any fever, sir, and patient is not having any constitutional symptoms, sir. So for tuberculosis also, there is no history of any contact history, or there is no no history of any previous history of any ATT intake, sir. And also, there is no clinically there is no swelling with discharging sinuses or any soft tissue proliferation, sir. Sir, for tumors like enchondroma or osteoblastoma,
Okay.
the patient is again having pain and swelling, sir.
Okay. Okay. Would you like to do any other investigation?
Sir, so blood work, sir. Lab investigation, sir.
Okay.
So can I proceed with basic blood investigation like CBC, ESR, CRP level, sir?
Okay. All within normal limits.
Sir?
All within normal limits, Akhilesh.
Sir, then we can see for ALP level, sir.
Okay.
And then calcium levels.
Okay. What do you suspect?
Sir, for ALP, like if there is, suppose it's a METS or something like that, then the calcium level should be elevated, sir.
Metastasis.
Yes, sir.
Okay. What is the serum calcium is 10.6 for this patient, and serum ALP is 153 international unit per liter.
So serum calcium seems to be normal, sir. Yeah. So then we can proceed with PTH levels also, sir.
PTH,
parathormone and phosphorus levels, sir.
Serum phosphorus is 2.7. And why do you want to do a parathormone?
Sir, rarely osteitis fibrosis cystic like conditions may affect the small joints, sir, like Brown's tumor and all. So, in case of primary parathyroid, hyperparathyroidism also, the small bones will be involved, sir.
Okay. How do you differentiate between the primary parathyroid hormone and secondary parathyroid hormone?
Sir, so primary, secondary, and tertiary, we can compare with the lab levels, sir, like calcium, phosphorus, and the PTH levels, sir. Okay. In tertiary, all the three will be elevated, sir. Okay. In primary, the calcium will be elevated, and in secondary, the calcium will be decreased, low or normal, sir. And the PTH levels will be increased, sir.
So primary, you have a calcium
elevation, sir.
Elevation. In secondary?
So, secondary, it can be normal or it can be decreased, sir.
Decreased, okay. Phosphate, primary?
Sir, primary, phosphates will be decreased, sir.
Okay. Okay. Serum parathermone is 1840. And would you like to do
hyperparathyroidism, sir? Primary hyperparathyroidism, sir.
Primary hyperparathyroidism. What other investigation would you like to do?
Sir, I will go on with the ultrasound of next thyroid and parathyroid, sir, to see the parathyroid, if there, to rule out adenomas of the parathyroid, sir. If it necessitates a surgery or not, sir.
Any other specific test?
Sir?
Any other specific test would you like to do?
So calcitonin levels.
Okay, any other non-invasive test would you like to do?
Sir, renal parameters we have to check, sir, for secondary hyperparathyroidism, to rule out the secondary hyperparathyroidism also, sir.
Renal parameters are normal. Would you like to do a skeletal survey?
Yes, sir. Bone scan studies we have to do, sir. Uptake study, sir.
Okay. Just a minute. This skeletal survey has been done.
Okay, sir.
Can you see anything?
So it's an X-ray APV of adult pelvis, sir, including the both hip joints, sir, including the lumbosacral areas also, sir.
Okay.
Showing the lytic lesions at the iliac crest.
Okay.
Again, the shaft of femur, middle third distal junction also, there is a lytic lesion, sir.
Yes. And you can see the humerus.
So I'll zoom and see, sir.
It is not possible for me. So what are the differential diagnosis for this multiple osteolytic lesions?
So multiple osteolytic lesions, sir. So multiple enchondromatosis, sir.
Okay, what do you call it? Any other name?
Sir, polyastosis.
Okay, any other
Polyastosis.
syndrome you know associated with it?
Maffucci
Polyastosis,
syndrome,
okay.
sir.
Any other syndrome?
Maffucci syndrome, sir.
What are the components? Good. What are the
Sir,
components?
multiple enchondromatosis with hemangioma, sir.
Hemangioma of?
Sir.
Hemangioma of skin and viscera.
Sir.
Okay, okay. Okay, any other? What are the other differential diagnoses?
Sir, multiple lytic lesions, so we can think about in multiple myeloma conditions, sir.
Okay. How will you, what is the against the factor in this patient for multiple myeloma?
Sir, lytic lesions in the skull, sir.
Okay. Normally, at what age will you expect for a multiple myeloma?
Old age, sir.
Sorry?
Above.
Okay.
Above
okay.
50, sir.
Okay, okay. Now the patient here, the page is...
Age is a young age patient, sir.
Okay, young patient. Okay. Any other differential diagnosis?
Sir, multiple. Secondary, sir.
Secondaries. Okay. Secondaries, the age, is it common?
No,
What
sir.
is the age of the patient, sir? Somebody's. What is the age, sir?
26,
sir.
26, sir.
26. Dr. Pari, it is only 26.
So any other?
Sir, Langerhans histiocytosis, sir.
Sorry?
Sir, eosinophilic granuloma.
Okay, okay. Eosinophilic granuloma. Then? As I told, some infection may be the DD. This is the blood investigations. So the scan is the system AB scan.
Okay.
System bone scan. Do you know the isotope used for this? Name of the isotope?
So iodine 1. So iodine 131, sir.
No. Technetium?
Technetium.
Say technetium 99. So you see the system AB scan, and
Okay.
you see the uptake in the inferior parathyroid
Okay,
on
sir.
the right side. Okay, so and there is
It's a
no
rare
other.
case of parathyroid adenoma, sir.
Yeah, parathyroid. So we have our surgical endocrinologists have removed the parathyroid adenoma, and from the follow-up, the parathyroid was 19.2. Suresh sir, do you want to ask anything?
Almost all the questions are asked. Now it is okay. I think Danapan sir, any you want to add anything? Danapan? No, it's not.
That's a
Okay,
very
no problem.
interesting case, sir.
Ah.
Interesting case. All the records in hand, sir.
Yes, sir. Actually, this patient just walked in to our OP with just a pain in the foot. So to be even we have taken the biopsy, and it was misleading us. It's given as an osteoclastoma like that. But we have done that blood investigations. Then we got the opinions, and we have treated the patient. Sir, can we move to the next?
Next case, third
yeah.
case.
Yeah, Akhilesh, good, Akhilesh.
Okay, thank you.
Okay.
Thank you, sir.
Okay.
Pari again. Dr. Pari again.
Pari?
Sorry, sir.
Third case is for you. Yes, sir, you can go ahead.
Pari?
Sorry, sir.
Yes, sir, he's online.
Yes. So this 21-year-old male is a student, and he had pain in the left shoulder for past 1 year, and on examination, no fixed deformity.
Sir, mic konjam pakkathula vechukkom. Our sir, mic pakkathula.
Yes, sir. Sir, the attitude of the limb is neutral in fusion inside of the chest with the elbow flexion at 45 degree, wrist in neutral, no deformity, and there was we can say deltoid muscle wasting.
Okay, sir.
On inspection, these are the movements available.
Okay, sir.
The flexion, extension, abduction, adduction are all movements are restricted. This was the clinical photo of the patient.
Okay, sir.
So this was the presentation, the X-ray.
Pari, read the X-ray.
Okay.
Can you read the X-ray, Pari?
This is a plain X-ray of the proximal humerus and glenohumeral joint showing pathological fracture of the proximal humerus extending into the articular surface, sir.
Okay.
AP view shows a light thick lesion in the proximal humerus, sir.
Okay.
Which have gone in for a fracture.
Okay. How will you proceed with this patient?
I'd like to have a CT scan of the proximal humerus, proximal arm and shoulder joint.
Actually, MRI was available.
Okay.
And actually, this patient came in this COVID period. Have done
Okay, sir.
initial treatment. Some R&D has come. Can I go to next slide?
Yes, sir.
Read the MRI, Pari. Just try to attempt reading the MRI.
Sir, sir. There is a fracture in the proximal humerus, sir, with fluid extrusion from the cystic cavity, sir.
How is the bone density in the proximal humerus? Whether it is normal or below normal when compared to the shaft of humerus?
Below
Comment
normal,
on the
sir.
comment on the proximal humerus alone, and the epiphysis metaphysis. So there is a lytic lesion, huh? Right? Some form of lysis. Yes.
Yes, sir.
Yes, sir. And there is a glenohumeral effusion. Okay.
Yes, sir.
The soft tissue component is also involved. Yes or no?
Yes. Yes, sir.
Yes. So this, keep on doing it. Okay.
Glenohumeral effusion is being shown in these slices, sir.
Okay.
Fracture, thin cortical bone which has gone in for a fracture, sir. Possibly. No trabeculae are seen within the cavity, sir. No evident trabeculae are seen.
Okay. Okay, very good. What would be the probable or
Differential diagnosis I would
Yeah.
like to do.
Yeah.
Aneurysmal bone cyst, sir.
Okay.
Aneurysmal bone cyst. Sorry, complete your sentence. What is it?
Aneurysmal bone cyst of the proximal humerus with pathological fracture, sir.
Pathology.
Okay, next.
Other diagnosis, other differential. Unicameral bone cyst, sir.
Will it produce a soft tissue collection in a severe glenohumeral effusion? There's a possibility. And how is the lesion, osteolytic lesion, whether it is uniformly dense or some stratification is seen, difference of radiological grading is seen. When it is a bone cyst means it is uniform intensity, simple bone
Yes, sir.
cyst.
Yes, sir.
The bone cyst means uniform intensity, but here it is not like a uniform intensity. There is some degrees of hyperintense, hypointense alternating like this. So bone cyst is a say third or the fourth possibility. Okay, then
So what will you? So what are the DDs, Pari?
GCT of the proximal humerus, sir.
Okay, GCT of the proximal humerus.
Unlikely location.
What is the grading? What is the name of the? How will you grade the GCT, Jailson tumor?
I'm not sure of the table, sir.
What do you say, sir? He is not sure of? You are not
I'm
sure
not
of?
sure of the classification used, sir.
I couldn't get you. What do you say?
I'm not sure of the classification used.
Class. Akhilesh, can you comment on the classification available for?
Sir, Campanacci and Jaffe's grading, sir.
Can you tell me something briefly about what is Campanacci, what is Jaffe's?
Sir, Campanacci is basically based on the radiological features, sir, and Jaffe is basically based on the histopathology, sir.
Okay.
So Campanacci, we are dividing into 3 types, sir. First, it's a cystic lesion, sir. Type 2 means cystic lesion with a cortical breach, but it is not going beyond the cortex, sir. And type 3 means the cortical breach is there, it is affecting the soft tissue, sir.
Okay, Jaff.
Jaffe's?
Sir,
Jaff.
So Jaff is also 3 stages, sir. Based on the mitotic activity of the cell, sir.
Okay, good.
Sir, more amount of based on the amount of the active mitotic cells and osteoclast, sir.
Presence of giant cell tumor and
Osteoclast, sir.
stromal cells.
Yes, sir.
So, what is the grading of this patient?
So it is Campanacci grade 3, sir.
Okay. Wow. What will you do? Or how will you proceed next? Pari?
I would like to immobilize this patient with a U slab, sir, for pain relief.
Okay.
Then take this patient for bone biopsy, sir.
Okay. What are the precautions I have to take while doing a biopsy? Akhilesh?
Sir, principles of biopsy includes first, the incision has to be contained in the future surgical site, sir, such that the future surgery should contain that incision. Second, we should prefer a longitudinal incision, sir. Then, so third thing, the biopsy we have to take, we should not go to the intercompartmental region, sir. We should not cross the muscular plane, sir. So fourth thing, should be done by the same surgeon who's going to undertake the final surgery, sir. Then, so then maximum tourniquet should not be used while taking a biopsy, sir. Then if a drain, maximum avoid keeping drain, and if drain is kept also, it has to be removed in second post-op day, sir. Then the biopsy has to be taken from the multiple, not from a single site, sir. It has to be taken from multiple sites in multiple directions, sir. To include the correct biopsy, sir.
Okay.
One more thing to add up, Agresh. This biopsy should be done at an institution where the elective surgery or the definitive surgery is going to be done in future. Okay. So biopsy is not at a peripheral institution, and the elective surgery at a tertiary institution is not also advisable. The team head or the surgeon who is going to operate finally the definitive procedure, they should do the primary surgery, that is a biopsy also. Okay. Second, you told it multiple sites of biopsy. It is not multiple sites. Single incision only you have to take. Your needle or your curettage only multiple directions, not multiple sites. It is against the principles. Okay.
Okay, sir. Thanks.
Thank you.
How will you any other treatment?
Sir, we can think about neoadjuvant chemo or radiotherapy, sir, if undergoing surgery, sir.
So it's you think it's a case of giant cell tumor, and how will you proceed?
So giant cell tumor also has got a tendency of mets to the chest, sir. So we have to take a CT chest also to rule out the mets, sir.
Okay, good.
Then for GCT, it's a local aggressive tumor, and it's a resection. You can go for a extended curettage, sir.
Okay. What do you mean by extended curettage?
Sir, actually by exposing the tumor site, you have to create a small hole in the cortex, sir. Then we have to curate out all the intralesional aspects, sir, and then we have to fill it with tumor-hospital agents, sir, like phenol or like bone cement or silver, right?
What is it?
Liquid nitrogen.
Okay,
sir.
And you are using the adjuvants, and you have to use remove all the tumor content. So you have to do a burr. You have to use a high-speed burr, and you have to remove all the tumor content.
Traditional tumoral content, sir.
Okay.
Then we have to fill it.
Okay. How will you how will you stabilize this for this patient? You've done. You will be extended curettage and bone cement. Any other?
Sir, so can we think about a replacement, sir?
Sorry?
Replacement, sir.
Replacement, sir. Yes, sir.
Oh.
Sir, other than extended curettage, sir, can we go for a hemiarthroplasty or a long-stem hemiarthroplasty, sir?
Okay. The age of the patient is 21 years.
Sir?
Age of the patient is 21
very
years.
young. He's very young, 21 years only. No?
Okay, sir.
Complications of arthroplasty are many. Suppose if you do hemiarthroplasty, it will go for erosion, grenade erosion subsequently. The other possibility is going for a reverse shoulder. Again, it's too young, 21 years only. Okay, so better to try. And the cortex articular surface is maintained. X-ray, you see the X-ray as well as I saw in the MRI also. The articular side, the cartilaginous portion of the proximal is maintained. Make an attempt to preserve the. It's not possible, then go for replacement at any time it's available. Okay.
Okay then. Okay, sir.
So, no, anything you were done for this case, sir? You are not done?
Yeah, sir. So.
Illa, sir. For this patient, any surgery has been done in this patient?
இல்ல சார், இப்போ ஆக்சுவலா இப்போ இந்த கோவிட் பீரியட்ல வந்திருக்காரு சார். திரும்ப இன்னும் வரல சார்.
Not yet. No, வரல.
Not yet. இன்னும் வரல சார்.
Biopsy alone has been done and is confirmed as GCT, sir.
ஆமா சார். அது ஆக்சுவலா வெளியில பண்ணிட்டு இங்க வந்தாங்க. திரும்ப இன்னும் பேஷண்ட் திரும்ப வரல சார் நம்மள்ட்ட.
Okay. Dr. SK has told what is the preferable extended preferable site for this. Since we cannot go by the deltopecular approach, what approach Dr. SK has asked. Because the biopsy is gone through the deltopecular approach, we again have to go through the same approach because we don't want to go to some other area and spread the tumor. So I will prefer to go by the same deltopecular.
The same, use the same.
This is the answer to Dr. SK. Any other questions? Okay. There is no question. Shall we wind up? Manohar sir, is there anything you want to add up? Is there anything you want to add up?
No, sir. No, sir. Just.
Hyperparathyroid case, sir. Hyperparathyroidism.
Okay.
How to decide on parathyroidectomy? How many? So there are totally 4 parathyroids to be identified and removed. So the decision on removing the parathyroids, how is it to be made? So
Actually, no. We actually the adenoma எந்த இதுல இருக்கோ அந்த 4 parathyroid இதுல இருக்கோ அது மட்டும் தான் இருக்கும். நம்ம இந்த கேஸ்ல பாத்தீங்கன்னா ரைட் சைடு இன்ஃபீரியர் parathyroidல தான் அடினோமா இருந்துச்சு. ஸோ அதை ஸ்பெசிஃபிக்கா வந்து they removed the adenoma. ஸ்பெசிஃபிக்கா அடினோமா தான் ரிமூவ் பண்ணிருந்தாங்க நம்ம கேஸ். இது ஒரு பேஷண்ட் ஏற்கனவே.
So we decided based on the morphology of the gland, sir.
Sorry.
Intra we decided based on the morphology of the gland. Or we do any pathologic investigations on table like pros and cons.
இல்ல ஆக்சுவலா நம்ம அது சிஸ்டமேபி ஸ்கேன் பார்த்துட்டு நம்ம அதுல வந்து எதுல அப்டேக் அதிகமா இருக்குன்னு பாத்துறாங்க. பார்த்துட்டு அப்புறம் இந்த சர்ஜிக்கல் எண்டோக்ரைனாலஜிஸ்ட் வில் இது வந்து ஆக்சுவலா இது ரெண்டாவது கேஸ் இது உங்களுக்கு இந்த இது பேரத்தைட் இன்ஃபீரியர் இது பிரைமரி பேரத்தைட்ஸ்ல நாங்க இது ட்ரீட் பண்ணது.
Mediastinum is to be regularly explored or based on the scan only we do, sir?
Sorry,
anomalous position of the inferior parathyroid, sir, that can be located elsewhere.
இல்ல அதெல்லாம் I think surgical endocrinologist தான் கேட்கணும் நினைக்கிறேன்.
Few questions, how to remove the endocrine tumor, all those things have to be dealt with the surgical endocrine. Few questions to be answered by the surgical endocrinologist. And one question here, Dr. SK, is the shoulder joint is infiltrated with the tumor cells, that is with the DCT, because of the fracture. What will it do, sir? In this case, it is only the spill of the tumor which is gone. And again, because the patient is in, we are making an attempt to preserve the bone. We are not going for a replacement. Replacement is only a secondary option. You try to avoid replacement at young age. So again, you have to give a wash, put the hydrogen peroxide, all those things, wash it away, and then go for a fixation. And Dr. John asks, how do you fix? Suppose if you say the cortex is well maintained, that articular surface of the proximal humerus is well maintained, you can add bone graft, either cortical or cancellous. Maybe you can add fibula also. Then do a regular philos plate. Okay, that answers your question. Tanapan sir, can you?
Yes, sir.
Can you want to add up anything for the cases?
It's already fully discussed. You have discussed everything, every aspect of this. It's a very interesting case for discussion. For short case, it's one of the commonly kept short case.
Shall we wind up, sir? Wind up, Tanapan?
Yes, sir. We can.
Sir has finished cases.
Yes,
so on behalf of all of you, TNOA and other coordinators as well as from our advisors, I thank Professor Manohar sir who has taken pains to organize in these COVID cases. All 3 cases are very interesting. All 3 cases brought very much scientific discussion. Chat box is full almost. So I thank Professor Manohar sir for bringing up these 3 wonderful cases from Salem. Thank you very much, sir. Thank you.
Thank you, sir. Thank you, Bari and Akhilesh and TNOA, sir. And
thank you, sir.
This committee. Thank you, sir. Thank you. Good night.
Ranapan, you want to add up anything, announcement?
Yeah, we will meet on next Friday with another interesting topic on spine. Thank you all.
Thank you, sir. Thank you.
Thank you, sir. Good night.
Thank you, sir.
Yes, you can wind up the session, sir.
Yes, sir.
Thank you, Ramesh. Alambic. Thank you, Ramesh. Thank you, JS.
Thank you so much, sir. Thank you.
Thank you very much.
Pleasure having you, sir. Thank you.
Okay. Thank you, Ramesh and JS.
Thank you, sir. Thank you. Pleasure having you, sir.
Yeah, thank you.